Everybody. Yeah, I think welcome back to our KIMS online sessions. So today I'll be discussing on epilepsy and seizures. I'm Dr. Jayanth Krishna. I'm a pediatric neurology consultant at KIMS Cuddles and also consultant in clinical genetics. So today I thought we'll take the session in 3 sessions. I mean, epilepsy and seizures is a huge topic per se. I'll be covering the basics of seizures, epilepsy, and a few definitions that we have, updated recently by ILAE, and also common classification systems and common misconceptions that we have. And in the second session, we'll be looking at various clinical videos on how to identify what type of seizure is it. And finally, the third session would be on epilepsy syndromes per se. I mean, the exact diagnostic criteria of various epilepsy syndromes. Online chala. Okay. So this is the starting slide. I think I tried condensing all the types of aura. You must have heard about aura is the event which happens right in front, right before the seizure starts. So before the onset of seizure, the feelings or the perceptions that the person gets is described as aura. So any child more than 7 years, I think it's very logical that we can ask for what kind of aura that is the patient can feel. And on the left, starting. So on the left side, if you see the first, on the left side, if you see, this is the picture of phenomenon of deja vu. So deja vu is basically a phenomenon wherein the person feels he has been in this situation before. So I mean, something feels very familiar about this particular event or this particular circumstance. So that could also be a part of aura in temporal lobe seizures. Okay, and jamais vu is opposite to deja vu. So even in the commonest situation that he has been to that place many times, but that place again looks very new to him. So that's quite opposite to deja vu. These are both aura which can be seen as a part of temporal lobe seizure. Not very common in children, but it's pretty common in adults. And on the bottom left, if you see, there are various colored geographic images. If you see like various circles, there are random geometric figures. So this is a typical aura what you see in occipital lobe seizures, because you all know that occipital cortex is our visual cortex. So whenever we have the seizure originating from that, the seizure can actually begin with these kind of images in the field of vision. So this must be asked specifically. I mean, a lot of children above 5 years, sometimes 7 years, definitely do mention this, that they kind of described as floaters sometime, but the term floater is not the correct term that we use for this kind of hallucinations. It's a sort of visual perception or hallucination. We use the term floaters for ophthalmological conditions like which is hemorrhage and which is type of clinical features. You use the term floater. On beside that, if you see this picture in black and white, there's different cartoon pictures which are describing various visual perception issues. If you see just beside the visual cortex, there's visual association cortex. So visual association cortex is basically the one which processes your image and it transforms to a bigger circumstance of an event or an image. So visual perception, if that is affected, I mean the seizure activity is spreading from the primary cortex to the visual association cortex, then you'll have all these symptoms, which can be in the form of body dysmorphia. It can be micropsia, telopsia. Micropsia is the original object looks smaller than what it's supposed to. Telopsia is basically the object looks very farther than it's supposed to, and macropsia is the smaller object looks very bigger. Telopsia is farther object looks actually very near to. So I had one patient who had NHPI, neonatal hypoglycemic brain injury. He typically describes a very farther appearing car, especially whenever he goes for a drive with his parents. So whenever he sees a car which is very far away in the road, but he could feel that in his hand's distance before the seizure starts. So that's called pilopsia. So farther object looks very near to you. Another phenomenon is micro and macro somatognosia. So if you split the word, micro is basically your body looks smaller than what it's supposed to look. Micro somatognosia. So it's type of agnosia. So it's not the true image, but it's your brain actually feels it. So all these are various type of auras which can be seen in occipital lobe seizures. Little bit about gelastic seizures. This is just an introductory slide. We'll describe. We'll also learn about these type of seizures in detail in the coming sections. Gelastic seizures are the seizures which start with a grin or a laughter or a smile. It localizes to temporal lobe seizure. Temporal lobe and sometimes frontal as well. Usually, hypothalamic hamartoma is the one which causes gelastic seizures. And we'll quickly go into various aspects of epilepsy, including very quickly about history, basics of seizures, definition of seizure, what is pseudo-seizure, epilepsy, seizure classification with the ILAE terminology, and seizure semiology, if time permits, or else we can do the seizure semiology and various clinical videos together in the next session. So quickly about the history, as you all know, few years ago, 500 years back, seizures were never thought to be originated from the brain. So they thought it was because of divine intervention and demonic possession and wrath of gods. This was the same concept which was going on across the entire world. Even in the Middle Eastern countries, like Assyrian literature, Akkadian literature, and Mesopotamia, Babylonian literature, and even before 1,000 years, it was thought that seizures actually came from demonic possession. And also, it's a religious belief that even in Indian religion, Indian culture as well, 500 years back, it was thought because of a demonic possession. So for demonic possession, that's why people used to use metal. Iron was one of the contracting agent for demonic possession. They used to use iron rods. So I put this picture because even in the current era, people in the cities still use iron rods, locks, and keys when a person has a seizure. So it doesn't make any sense. But sadly, that's the truth even in the current era. And even the educated people actually go do that. So that should not be done. This is just completely been debunked. So another practice which was debunked, it was late 15th, 17th century. Trephination was used. Trephination is a procedure where they do, not in a septic way, they do burr holes into the skull so to relieve the pressure. So this kind of used to work temporarily because it's going to decrease your raised ICD and the tension is to go down, but eventually the patient dies because of an infection and sepsis. So this concept was used in seizure and also encephalitis as well. So then one of the picture depicting that iron has nothing to do with seizures, just a belief which was there 1,000 years back, because iron was believed to be the one which contracts the malevolent spirits. I don't know. So this is when everything changed. This is somewhere at 400 BC, where a lot of scientific research actually started. This is not only in neurology and not only in epilepsy and not only in seizures and this culture. Apart from neurology, the entire science actually evolved in a very right direction from this part of years. Especially in the Hippocrates time. So that's why they call this the dawn of scientific understanding. So at this time, Hippocrates was the first person who actually said that seizures originated from brain and not from malevolent spirits or demonic possession. And not to undermine the Indian literature, if you see Indian literature at this very same time in 400 BC, Chiraka Samhita is one of the literature which says that seizures, blackouts, and loss of consciousness actually could localize it to the brain. So Indian people also had this understanding that it originated from brain, because back then we never had any imaging. There's no CT, there's no MRI. The only type of understanding we had at that time is follow the patient who had disease until the disease progresses and the patient dies, and do a necropsy or an autopsy to find out what exactly happened. So that was the only way. So even at that, with little amount of understanding, so they could localize it to the brain. So this is a slide which quickly demonstrate various milestones of anti-seizure medications. So one of the first anti-seizure medications was in 1850. That was potassium bromide. It's one of the oldest ones, and phenobarbital was one of the oldest, and we still use phenobarbital in neonatal age group, one of the oldest drugs. And then came in 1940s, we used mefenitoin, acetazolamide was one of the drugs which was rampantly used in seizures and epilepsy. And then there was a time wherein a lot of new drugs came into existence in 1950 and 1960s in the time of independence. So we had 1950s, we had trimidone and pensuximide. In 1960, then came a groundbreaking drug in focal epilepsy, that is carbamazepine. So that actually revolutionized epilepsy management, and also benzodiazepines. So benzos came in 1960. The first one was diazepam. And in 1970, you had other second generation benzodiazepines like clobazam and clonazepam. So that was in 1970s. And then came newer generation ones, lamotrigine, oxcarbazepine, felbamate, gabapentin, topiramate, levetiracetam in 1990. And in 1980s, just before that, vigabatrin and zonisamide came off. And in 2000s, after 2000, you had lacosamide, rufinamide, stilbentol. And now currently we are in the generation of precision medicine. We have very tapered or tailored use of medicine for that particular mutation. So perimpanel is one of the AMPA receptor blocker. Reticabine is again used in very specific conditions. Privilistam, everolimus, a targeted drug in tuberous sclerosis. I mean, 2020 and after 2020, it's an era of precision medicine. We exactly know what is the cause of epilepsy with genetics. We know the exact gene mutation, and we try to target that with one specific drug. So that's called precision medicine. So we do precision medicine itself is a different topic. I won't go into the details of it. And also, if you see, the current era is precision medicine because in the current era is also the era of genetics. Because we have the exact gene mutation, we know the exact precision drug which can be used. So why do I say it's the current era is genetics? Because back then we had only few genetic mutations which are very well described for epilepsies. That were one of the first mutation was CHRNA1, CHRNA4. This is one of the epilepsies which is called autosomal dominant nocturnal frontal lobe epilepsy. So after that, then came sodium channelopathies, potassium channelopathies. We had GABA receptor mutations. We had other type of mutations coming up, and then we had later understanding of microdeletion syndromes, which have a consecutive gene deletions, which can cause epilepsies. So I won't go into the detail, but we'll have one session on precision medicine later on. So as I was saying that, the understanding of genetics as it went on, we also had understanding of precision medicine. So both of them obviously went hand in hand, because without the understanding of gene mutation, we don't come up with a precision medicine, right? So quickly about the history of DNA sequencing. If you see 1975, Frederick Sanger, for the first time, introduced Sanger sequencing. Sanger sequencing was one of the laborious processes wherein with a large amount of time to sequence one particular gene, it's going to take days and days together. I mean, to sequence the entire DNA of one particular patient, the entire DNA, it's going to take months and months and years also. So Sanger then immediately, it was advanced to second generation sequencing in 2000s and late 90s. This is basically the technique for what we use currently, that is pyrone luminous sequencing. This is called the second generation sequencing. This is also called the short read sequencing. So this is where currently we are. We use whole exome sequencing, clinical exome sequencing. All these are second generation sequencing. And very quickly, in the last couple of years in India, we are quickly moving on to third generation sequencing. That is, it's called long read sequencing, or the technique is nanopore sequencing or PacBio. So this is the third generation sequencing is more advanced than second generation sequencing. It's called the long read sequencing. It is not going to miss the mutations which are or the variants which are missed on second generation sequencing. And also there are a lot of other advantages that it's going to cover deep intronic variants. It's going to have coverage for many different things which are not covered in second generation sequencing. So with the advances which are happening so rapidly in DNA sequencing and exome sequencing, the third news is basically whole genome sequencing. So we are understanding more about epilepsy, more about epilepsy genes, and more new drugs which can be used in epilepsy. So this is one slide quickly for the precision medicine. So precision medicine is basically, as you know, it's drug tailoring. You know the exact mutation of the gene. You have the exact mutation of the epilepsy, and you know the exact drug which particularly acts against that particular mutation. So you have a very good response because you only have monotherapy, and you're exactly targeting the root cause. See, when it comes to precision medicine, the precision medicine usually should target the root cause and not the final effect. See, even in a sodium channelopathy, if you give levetiracetam to that particular child, the child is going to initially respond because levetiracetam is non-specific. It's going to have seizure control, but you're not targeting the root cause. So if it's a sodium channelopathy, you need to understand, is it loss of function or gain of function? If it's a gain of function mutation, you have to give sodium channel blocker. Or if it is a loss of function mutation, what you see in Dravet syndrome, you have to avoid sodium channel blockers and you have to give other drugs like valproate, stilbentol, cannabidiol, and clobazam can be given. So it needs to be understood in a very depth. I mean, you need to understand what exactly is the mutation, what kind of mutation is it, what kind of variant is it, is missense, nonsense, what channel is being involved, and what is the downstream effect of that particular channel. I mean, is it gain of function or is it loss of function? All this needs to be understood well, and then accordingly you have to start the medicine. So I quickly give you one or two examples. SLC2A1 is one of the gene which causes GLUT1 deficiency. It's one of the neurological conditions wherein the precision medicine is not a drug, it's a ketogenic diet. So ketogenic diet itself is a first line agent in this medicine. I mean this condition. So usually children directly respond to only ketogenic diet. You don't need a second line agent or an anti-seizure medication per se. Another example is the common one is sodium channelopathy. What we commonly see is Dravet syndrome. Dravet syndrome is basically SCN1A, wherein you have loss of function mutation. That sodium channel is not working. So you know that sodium channel is not working. So you should never give sodium channel blockers. So you have to know all the sodium channel blockers. I won't go into the details. That's another session of anti-seizure medications. So that is one of the examples. And you have various potassium channel mutations as well, KCNT1, KCNT2, KCNQ2. All these, most of the potassium channel mutations also respond to sodium channel blockers. So quickly, there's one more specific epilepsy, which is called CDKL5. In that you have a specific precision medicine called ganaxolone that can also be used. So these are the examples of the precision medicine. In the center part, if you see, this is basically the rapamycin derivatives, NPRN2, TAC1, TAC2. So basically, everolimus and sirolimus are the drugs which are used to counteract this. I mean, they are not only used in epilepsy, they are also used to decrease the burden, decrease the size of SEN and SECA in tuberous sclerosis. So that is about precision medicine. So quickly, I mean, a very important slide. ILAE is International League Against Epilepsy. It's an organization wherein it's one of the oldest organizations for epilepsy in pediatrics and as well as adults. So here we have various meetings organized from various countries, and they form guidelines so that we have a common terminology and common literature and also common language. So that is very important because you can't use various terms for the same meaning. For example, we don't use the term petite mal epilepsy. We don't use grand mal epilepsy. We don't use the term pycnolepsy. Because when you try to use these words, there's no common union. I mean, if you publish a study saying that, the clinical spectrum of pycnolepsy from one place, obviously it's not going to be picked up in a meta-analysis if somebody is trying to do a review literature. So, I mean, ILAE exactly focuses on the aspect that, we all need to use the same language for what we mean so that we have more literature and we can combine the literature and also can do multicentric studies. So what is the problem in seizures and epilepsy, not only in pediatrics, but also in adults? In adults, the seizure semiology, I mean, is more defined, well-defined. It's like focal seizure or generalized seizure. It's very easily seen in an adult. You have a focal onset seizure, which is spreading to bilateral tonic-clonic seizures. Very often, by the time the adult sees this, we'd say have a generalized tonic-clonic. So it's GTCS or focal seizure in adult. But in children, it's a little more complicated. I mean, as more and more the child becomes young, I mean, if you in infancy and neonatal age group is even more tougher to identify a seizure because there are various types of seizures, and also a major chunk of abnormal movements are not seizures. So in children, it's a very common practice that any sort of abnormal movement, in the subtlest doubt of it, people start levetiracetam and then see that whether it's working or not. And they go with the logic thinking that, no, I'll start levetiracetam and see if the movement stop, it's a seizure. Not necessarily, because seizures can have various frequency. Despite you starting levetiracetam or not, it has a course to follow. And we'll see, I mean, starting levetiracetam in a non-epileptic, what are the consequences of that? But that should not be the practice. We need to identify what exactly is that. We need to first, the question is it a seizure or not? That needs to be identified. And then the other questions would come onto what type of seizure is it? What is the best medicine for that? What is the root cause of it? Then that's the next question. So this the entire slide actually depends on the concept that why is it so important to identify. So the first important thing is seizure semiology. Try to identify what exactly is the type of seizure. I mean, what is the movements which are happening. That's called seizure semiology. So semiology is basically the description of the event which has happened. Always important to ask whether could they record the video, because most of the time the description that parents give may not be completely factual, or may not be complete. The seizure may not be the complete description. Um, Home videos are extremely important, and that is a part of the main detailed history. And family history is extremely important, as you all know. Autosomal dominant epilepsies are very common in genetic channelopathies. Perinatal history, again, an autosomal recessive would be important for inborn arrest of metabolism seizures in first 2 years of life. There are few X-linked conditions. There are autosomal dominant frontal lobe epilepsies. So family history is extremely important. Even in a febrile seizures, a direct family, even parents and close cousins will have history of febrile seizures. Perinatal history, again, perinatal asphyxia, neonatal hypoglycemic brain injury, perinatal stroke are one of the prominent predisposing factors for gliosis and structural epilepsies. Later on, can have onset of epilepsy. Developmental, because a lot of conditions, genetic conditions, can have developmental delay, regression, and with seizures. So that's why we use the term DEE, that is developmental epileptic encephalopathies. So development is going to be extremely important in the case of epilepsy. And past history, any previous events. For example, if the child is seizing at the age of 7 years or 8 years, you need to definitely ask what did he have similar events or any other events in the first 3 years of life. A quick example is, a child who had continuous febrile seizures, and after 8 years, he's having unprovoked seizures. So this could go into the spectrum of JEFS plus, that is generalized epilepsy with febrile seizures plus. So it's a condition wherein child starts to have febrile seizures and later on it will have unprovoked seizures. So this is commonly seen in sodium channelopathy spectrum, almost the Dravet spectrum. Okay. And personal history is again important in adolescent children who have um, uh, recreational habits like smoking, alcohol withdrawal, cannabis withdrawal. All this are extremely important. Adolescent patient is coming to you because all sort of withdrawals can cause seizure. So there's no point getting an imaging and EEG and genetic testing in a patient who has had alcohol problems since last 2 years and he had sudden withdrawal because of some reason. So personal history should include all that. And also recreational drug use, including glue sniffing and many other drugs which can actually provoke seizures. And the rational investigations, what do I mean by rational investigations is basically there's no single formula for any child coming to you with seizures. I mean, any child who walks in with seizures and epilepsy do not get the entire bunch of MRI with epilepsy protocol, EEG, blood, genetics, CSF. No. So it should be tailored to the patient. I mean, on one single investigation can be sometimes enough for a patient. For a patient with a suspected autosomal dominant nocturnal frontal lobe epilepsy or BEX, BEX is now called SELECT, Rolandic epilepsy, wherein you have night seizures only. You don't have to get an MRI. You can get an EEG and start treatment per se. So rational investigations are where the person needs to understand what exactly or the test would give him the consequence of that. So MRI to look for structural causes. There is ICSOLs, acute symptomatic seizures, neurocysticercosis, tuberculoma. All that needs to be seen. Perinatal asphyxia, if there's gliosis or not. NHPI, look for occipital gliosis. MRI would be a very important clue to find out structural etiologies. EEG gives you different type of information. EEG tells you where exactly is onset of seizure, what kind of waves are there, is it spikes, is it continuous discharges, what kind of seizure is it? It gives you clues about is it an absence semiology, juvenile myoclonic epilepsy, or a focal onset seizure. All that information comes from EEG. EEG also gives you information about electrical seizures and non-convulsive status. So different kind of information comes from MRI, different kind of information comes from EEG. Blood investigations, I mean, sometimes acute symptomatic seizures, you need to look at hypoglycemia, hyponatremia, hypomagnesemia. CBC sometimes to rule out neonatal sepsis and infection. And some blood investigations also like interleukin values, autoimmune encephalitis when you're suspecting serum and CSF autoimmune encephalitis profile. Genetics, in a suspected genetic epilepsy, that could be whole exome sequencing for single gene mutations, and also sometimes chromosomal microarray can also have epilepsies. And sometimes, rarely, karyotyping can also be done in epilepsy in ring chromosome 20, where epilepsy is the predominant clinical feature of that particular condition. So it should follow an order of a very good clinical history, semiology, home videos, history, including family, perinatal development, past and personal history, followed by rational investigations, and then plan to start a medication. And again, the whole etiology is very important, and try to fit what exactly is epilepsy, and then you decide the drug. And then maybe consider levetiracetam. Not necessarily levetiracetam; it can be anything which suits for that epilepsy. We'll decide. We'll also read about the classification. Then what do you do? Now you know that there's seizures. Now you know the etiology. Then how do you put it in the ILAE framework? So ILAE framework is extremely important. We'll discuss this in the coming slides. So do make use of the latest technology here. If you see, for a patient who has difficult epilepsies and we don't understand what type of epilepsy is it, we have epilepsy units, pediatric epilepsy units, and also adult epilepsy units, wherein the child is admitted for a couple of days or maybe sometimes 2 or 3 weeks, wherein he's continuously monitored with a 24/7 video HG monitoring system. So sometimes that can be tedious and expensive for the parents. So we also have home equipment where home videos, home EEG is done. So in the first picture on the left, if you see, the person is attached to the home video EEG machine, and he can have a normal life. And anytime if he has a seizure, that will be captured in the video system, and later on it can be analyzed by the doctor. And the same thing can be seen, can be done in the hospital as well. If you see the bottom left, it's a video EEG system which is done at home and done at a hospital. And if you see the top right one, is basically a lot of videos because of rampant use of screens and gadgets. Now we are able to capture a lot of home videos. So home videos are going to be extremely important. Myoclonic jerks happening every day, epileptic spasms. So sometimes captured in home videos, that can be important. And we also have technology of night camera now, because especially night epilepsies like, Rolandic epilepsy, that is Select's, Beck's, autosomal dominant frontal lobe epilepsy, Panetopolis syndrome, now called Celia's. All these are syndromes wherein you have only night events. So night camera with this night lens, it's very useful in these patients to capture the event and also to diagnose the seizure. So as you all know, seizure definition, what is the difference between seizure and epilepsy? Do not confuse that seizure is just one event we are trying to describe, whereas epilepsy is a tendency to have 2 or more unprovoked seizures. We'll also see the ILAE definition of epilepsy. So if you see, seizure is a sudden temporary disruption of normal brain function caused by abnormal excessive synchronous neuronal activity, which can lead to changes in behavior, movements, feeling, and level of consciousness. So you need to understand seizure may they've then clearly mentioned in the system it can lead to. It's not always mandatory that the child will have changes in movement, child will have changes in behavior, or the loss of consciousness. It's not mandatory. They may have. So there are electrical seizures. The child may be absolutely normal, or he just stops whatever he's doing, but he can have a seizure. So that's called a motor arrest or a behavioral arrest. You need to understand. So definition of seizures, it's an excessive synchronous activities going on in the brain that can sometimes be manifesting physically and sometimes may not. Okay. And as I said, seizure is a single entity. Epilepsy is a tendency to have more and more seizures. So we'll see the exact definition of epilepsy. So epilepsy definition has been clearly given by International League Against Epilepsy. So here you have 3 criteria. So any one criteria is enough to define epilepsy. The first criteria is you have 2 unprovoked seizures 24 hours apart. For example, I have a child with 1 episode of seizure, and within after 2 or 3 hours, he has another episode of seizure, then that won't be epilepsy, because that I would think of acute symptomatic seizures in that condition. So if a patient has 2 seizures 24 hours apart, then it goes into the definition of epilepsy, and the work would be completely different. Second, this second criteria is put forth. You need to understand that if the person has 1 unprovoked seizure, you can't tell the parents that no, he just has 1 unprovoked seizure. We'll have to wait for the second event to happen. Then only I'll try to understand if he has epilepsy and then work up. Sometimes it doesn't make sense, or the parents obviously don't understand the concept. They also becomes restless. So if the patient has 1 unprovoked seizure, then you need to work up the child to understand if there's a recurrence chance, whether he'll be prone to have second seizure. And in that workup, if you feel the recurrence chance is more than 60% or high, then this also goes into the definition of epilepsy. So one unprovoked seizure plus workup suggestive of recurrence. For example, I'll give you a patient has come to you with one episode of unprovoked seizure, and I did an MRI. MRI is suggestive of periventricular leukomalacia or NHPI. So I know that MRI is showing gliosis. This patient will have a high risk of recurrence. So this will go into the definition of epilepsy. So that's one of the example. Not only MRI, I could do an EEG. EEG can show showing epileptiform discharges. So that will go into epilepsy. Or I do a genetic test because there's a strong family history, and I found I have a patient with SCN1A mutation in one sibling, and the second sibling also had one abnormal movement. The second sibling is also positive for SCN1A. So one episode of unprovoked seizure with a genetic diagnosis is also an increased risk factor. So we can classify that as epilepsy, and you can start medications. Third definition is basically the seizure directly falls into the definition of epilepsy syndrome. For example, if a baby is brought to you with the history of epileptic spasm or one cluster of epileptic spasm, you can't tell the patient that it's only first episode, I can't start treatment, because epileptic spasms, you have to call the baby and you have to get an EEG right away. And if you have to document hypsarrhythmia and developmental arrest, this particular entity will directly go into the definition of epilepsy syndrome, that is West syndrome. So you have to start, you don't have to wait for a second event. So the definition includes 2 unprovoked seizures 24 hours apart. Second criteria is 1 unprovoked seizure plus recurrence risk is very high, that is more than 60%. Third would be diagnosis of directly epilepsy syndrome. So these are the 3 points wherein you can define an epilepsy. Quickly about common causes of acute symptomatic seizures. So this is a picture which is put for adults. I would change it or maybe extrapolate it to children when I talk. So broadly, if you see any seizure can be caused, what are the acute symptomatic seizures which you have to rule out? First is infection, inflammation, metabolic, structural, environmental. So these are the 5 things. I think this is the dictum for any sort of pathology in any subject. Infection, inflammation, metabolic, structural, environmental, and sometimes neoplastic. In children, infections are very common in neonatal age group, neonatal sepsis. In adults, meningoencephalitis. Ask for history of seizure, history of fever, altered sensorium, may do an LP to rule out symptomatic seizures. Then metabolic, in children, I would think of hypoglycemia, hypocalcemia, hyponatremia, hypomagnesemia, and hypoxia in children, in neonates. So all this, and followed by inborn errors of metabolism in the first 2 years of life. If you see small molecule inborn errors of metabolism, which include urea cycle disorders, organic acidemias, amino acidopathies, fatty acid oxidation disorders, all this will present, 90% of them present in the first year of life. So they can present with seizures. In that, metabolic workup should be your top. In that particular condition, you have to do glucose, ammonia, urine for ketones, and then go for GCMS, TMS. So you have to go in that line. So it depends on your case. Then in the inflammatory in children, celiac, Hashimoto's, and autoimmune disorders are very rare. In children, autoimmune, you have to think of demyelination and followed by fires. In demyelination, you have ADEM, you have NMO, all these can cause acute onset seizures. Sometimes lupus. And another common one is fires, that is febrile infection-induced refractory epilepsy in children. Is another important inflammatory cause of seizures. Coming to structural can be perinatal hypoxia, that is gliosis because of HIE, gliosis because of neonatal hypoglycemia, gliosis because of perinatal stroke. All these can cause structural etiology, and sometimes malignancies, AV malformations, post-surgical scars, traumatic brain injury, all these can be structural. Toxic and environmental, and in children could be, as I said, an adolescent boy or a girl coming with alcohol withdrawal, drug withdrawal, substance misabuse, and then followed by withdrawal, sleep deprivation. All these are common causes of seizures in children. The spectrum is slightly different. The order needs to be changed in neonatal age group. In neonatal onset epilepsies, think of the common transient metabolic derangements like hypoglycemia, hypocalcemia, hyponatremia, hypomagnesemia, and then hypoxia in the first 24 to 48 hours. After thinking about all this, think of perinatal stroke. Okay. And then think of perinatal infection, perinatal sepsis with neonatal meningitis. After thinking about all this, then think of metabolic disorders, that is small molecule disorders. Typically, the child is fine in the first 4 days. child has a normal delivery, has a normal perinatal transition, baby was started on feeding, and the fourth day, the child has completely developed, poor feeding, drowsiness, and then has a seizure. This is typically still what you see in a small molecule metabolic disorder, typically MSUD or organic acidemia, glutaric aciduria, isovaleric acidemia. So you have to go in that line and think, then maybe get ammonia lactate, urine for ketones, and then get GCM stimulus and whole exome sequencing, and then stop feeds. So your treatment and the management depends on the etiology we are thinking. And lastly, after thinking about transient metabolic derangements, hypoxia, ischemia, stroke, infection, then metabolic, and then finally think of genetic channelopathy. So this should be order commonly which needs to be followed in neonatal age groups. And also remember, drug-resistant epilepsy is pretty common. What is the definition of drug-resistant epilepsy? The ILAE clearly defines that you need to use two trials, the failure of two trials of two appropriately used anti-seizure medications to attain seizure freedom. So here, remember, two correctly chosen drugs at correct dose and correct duration, and they have failed to control seizure, and then becomes drug refractory. If a child with epileptic spasms is brought to you and you start the child on levetiracetam and oxcarbazepine and you say it's drug refractory, no, because you have not chosen the correct drug. Levetiracetam and oxcarbazepine are not the correct choice of drugs in epileptic spasms. So obviously the child will become drug refractory. In the same way, in a myoclonic seizure, if you go oxcarbazepine or carbamazepine, the seizures will increase. So you need to use the chosen drug for that particular epilepsy. In epileptic spasms, if you have used steroids, maybe valproate or vigabatrin, and after two trials of, also have to use the exact dose, correct dose. Start at the right dose, go up, and even after, despite the correct dose and a good dose of that drug, the child is being refractory, then you call it drug refractory epilepsy. Okay, and then coming to the classification system of ILAE, this will do it in detail in this session. So there has been a lot of change in the last 10 years. We don't use the terms which were used before. We'll also discuss about what terms are not used anymore. So here, the classification is simple. ILAE defines the seizure as a focal onset seizure, generalized onset seizure, or unknown onset seizure. So ILAE basically concentrates on the onset. It's not about the whole duration of seizure we are trying to describe. For example, the child may have focal onset and then later on will go into bilateral tonic-clonic or GTCS. So the ILAE doesn't care about what happens next. It is only talking about the onset. Because onset is very extremely important to identify the etiology. So in a focal seizure, I would like to get an MRI and look at what is the structure, what is the cause of exactly focal seizure. If I'm describing a patient who has generalized tonic-clonic seizure who had focal onset seizure, then doesn't make any sense. So the onset is very important. So whenever you take a history and the patient or the father does not remember, see, very often situation what happens is basically the child will be in a separate room and the parents hear the noise of fall or the noise of gurgling sounds or something, and then they go inside, they see the child seizing. So here, what has happened? The parents have not seen the onset of a seizure. No, they've seen the middle of the seizure. So in that case, it won't be a focal onset seizure or a generalized onset seizure. Then it should be unknown onset seizure because they have not seen the onset. Again, this is very important because in a focal onset seizure, I would emphasize on MRI. Generalized onset seizure, maybe I'll wait because what if the child has juvenile myoclonic epilepsy? I won't get anything on MRI. Or a febrile seizure, I won't get anything on MRI. So when you don't know the onset, don't commit to it. Say it's an unknown onset. So the moment you say focal onset seizure, then you ask about loss of consciousness is there or not. If the child is aware, sometimes in focal onset, the child is completely aware. He describes the entire event. I started having movement in the right hand, I had numbness, I had movement of right hand, and then twisting of it. Then I felt very funny on the left side of the face. They describe sometimes. So that is the focal aware seizure. Second type is focal onset with impaired awareness. That is the child loses consciousness, but still has only focal type of semiology. So that is the second type of focal seizure. And the moment you describe focal onset seizure, it is aware and unaware. Then mention about motor or non-motor. Sometimes, if it is a temporal onset seizure, there won't be any motor manifestations. Okay, because temporal onset seizure, there's motor cortex is not being stimulated, and the electrical spread has not gone to the motor cortex. So only temporal onset seizure will not have motor movements. So it can be a non-motor seizure. The child will just have motor arrest. Whatever he's doing, is just stop doing it. And sometimes you can have motor manifestations if it's spread into the motor cortex. So it can be motor or non-motor. And once you have motor, it can be focal onset, or it can be focal onset with secondary bilateral tonic-clonic seizure. So we don't use the term focal onset or partial onset with secondary generalization anymore. We use the term focal to bilateral tonic-clonic. This is the newer terminology. And we don't use the term partial onset seizures. That's been completely replaced by focal onset seizure. And we don't use the term pygnolepsy for absent seizures. We don't use the term grand mal seizures. We don't use the term petit mal seizures for absent seizures anymore. So all these are obsolete. Don't use them. Then you have generalized onset. Again, here tonic, motor or non-motor. In motor, you have tonic-clonic movements and other motor movements. We'll discuss that. In the generalized onset, remember non-motor, and then you have absence seizure. So any child who has blank staring episode is not absence seizure. Remember, absence seizure, to commit to an absence seizure, you have to have an EEG correlate. The EEG correlate in a 3 Hz spike or a variant of it, then only you call it absence or atypical absence. If the child just has a blank staring episode, you describe the event as blank staring episode or a motor arrest or a behavioral arrest. Don't call it absence seizure. But absence seizure needs an EEG confirmation. And that if that has come positive, then you classify that absence seizure as generalized seizure. So it can be classified as generalized onset, a non-motor seizure. All right. And if you have not seen the onset of it, do not commit, just say unknown onset. Unknown onset can also be motor, non-motor. In motor, you have tonic-clonic and other type of seizures. In non-motor, you have absence seizure. Okay. That is the classification of seizure. And then once you classify, we'll also discuss the detailed version of the seizure classification, which is there in the next slide. But once you classify the seizure, then you try to classify the epilepsy as well. So on the top of it, you have identified it's a focal seizure, generalized seizure, or unknown seizure. Then you try to figure out it's focal epilepsy, generalized epilepsy, combined or unknown. Then does it fit into the criteria of epilepsy syndrome? And then after that, the child has some comorbidities or not. Then also etiology, the structural, genetic, infectious, metabolic, immune or unknown. So I'll give you an example. If the child has come to you with epileptic spasms, so epileptic spasms, bilateral symmetric, the child has generalized seizures. So epileptic spasms will be going into generalized seizures. Epilepsy syndrome, it's a generalized epilepsy syndrome. Epilepsy syndrome, yes, epileptic spasms with modified hypsarrhythmia and developmental errors, it go into West syndrome. So epileptic spasms, generalized seizures, West syndrome. Comorbidities, this child has HIE. Okay. And that will go into structural. So this is the ILAE framework of the exact description of epilepsy. We'll take another example. Let's say the child had focal seizures, left focal seizures. Epilepsy type would be a focal epilepsy. And then I did an MRI. The MRI showed gliosis because of perinatal stroke. So epilepsy syndrome, it won't be an epilepsy syndrome, it's a focal epilepsy. Comorbidities, this child had perinatal stroke. And it will go into structural. All right. Okay, let's take another example. A child had absence seizures. Absence seizure will go into generalized seizures. Epilepsy type, generalized epilepsy. Epilepsy syndromes, yes, juvenile absence epilepsy because the EEG confirmed the typical 3 Hz spikes. Comorbidities, this child has OCD and hyperactivity. Etiology, absence seizure is we know that it's genetic or unknown. So this is the framework of ILAE. I was talking about this is a detailed classification. I've already discussed this focal onset, generalized onset, unknown onset, aware or unaware. In the motor onset, you have various type of motor movements. So the motor movements can be, physical manifestations. That can be, we all know that it can be tonic, clonic, myoclonic. Or sometimes you have hyperkinetic movements in autosomal dominant frontal lobe epilepsy, like, very violent movements. Epileptic spasms. Remember, epileptic spasms can be focal, also generalized. Generalized onset epileptic spasms is more common. Sometimes focal onset epileptic spasms can also be seen in some conditions where there's only pathology on one side. Like sometimes you can be seen in hemimegalencephaly. It's called asymmetric spasms. They also have hemihypsarrhythmia on EEG. So usually generalized, but can also be classified in focal epileptic spasms. Tonic-clonic, I've already discussed. Sometimes atonic, sometimes child suddenly loses tone. That's called atomic. And automatisms can be any sort of random, nose swipe, face swipe, buttoning, unbuttoning, pill rolling movements. All these are automatisms. Non-motor onset, I've said, the child can just have behavioral errors or sometimes cause excessive sweating, cyanosis, pallor, emotional and sensory. These can be non-motor onset. See, autonomic manifestations can happen in temporal lobe seizures, Panatopolis syndrome. Behavioral errors can be seen in temporal lobe seizures. And these are some of the example of non-motor seizures. And once the focal onset seizure is spreading to the other side, then you'll have focal to bilateral tonic-clonic movements. The same type of classification is seen in generalized onset seizures, motor and non-motor. Motor, you have tonic-clonic, tonic-clonic, myoclonic, myoclonic atonic, epileptic spasms again here. Non-motor, typical absence seizures, atypical absence seizures, myoclonic and eyelid myoclonia. We'll discuss about these examples in the future sessions, wherein we have specific diagnosis and videos also. Unknown onset, as I've said, motor and non-motor. And sometimes you cannot classify, it can be classified under unclassified seizures. So overall, this is the change which is there. The first things is first, partial onset seizure is not used anymore. So we use the term focal onset seizures. Second thing, seizure types have focal, generalized, or unknown onset. And aware, simple partial seizure, complex partial seizure, we don't use the term anymore. We use the term focal aware or unaware. Then the terms like dyscognitive, simple partial, complex, or psychic, secondary generalized are not used anymore. The newer terms which we use are automatisms, autonomic seizures, behavioral errors, cognitive, emotional, hyperkinetic, sensory, focal to bilateral tonic-clonic, epileptic spasms, eyelid myoclonia. All these are terms are newly introduced. We'll discuss about that in the syndromes. So again, why is it so important to differentiate generalized and focal seizures? In focal seizures, I would be interested in looking at what exactly is the pathology. I would be running for MRA. I'd be looking at neurosis, tuberculosis, ICSOL, tumor, and maybe they have potential treatment rather than starting the patient on anti-seizure medications. Whereas generalized seizure, I would be, thinking more of EEG and then get an MRA and try to understand what exactly is going on. Maybe think genetics is the cause, etc. So this is another crowded and important slide. What are the phases of seizure? And this is very important to understand because whenever we talk about seizure, we only talk about the ictus. Ictus is the event which has happened. Parents come and say that, no, my child had the tonic-clonic movements, no, haath pair bahut tight kar diya. That's it. That is all we talk about. But everything which happens before that and after that is extremely important to know the exact cause of the seizure. So the ictus is very important. It's a focal seizure, generalized seizure, or what type of seizure is it? That is ictus. So what happens before that is a phase of aura. Aura, we all know, it can be visual, auditory, sensory, olfactory, autonomic. It depends on the seizure, which part of the brain is it coming from. Visual from occipital, auditory from temporal lobe, sensory can be from sensory cortex, olfactory from frontal lobe, autonomic from temporal lobe. So this is the various localization of various type of aura. What is a prodromal stage? Prodromal stage is right even before the phase of aura. Aura is just before the seizure. Aura will be followed by seizure, but prodrome is little before. For example, some children who are school-going children, very smart children, they know in the early morning itself that they are going to probably have seizure in that day, maybe in the night or in the evening. They have some sort of a weird feeling that day, but they may have a seizure. It could be some subtle irritation, subtle headache, something like that. And they sometimes, they'll not go to the school also. They say that, they're going to have seizure and they end up having seizure. That's called the prodromal stage. Not very common, but some adolescents will describe this, and some adults also describe this. And before even the prodromal stage, what you need to know, extremely important, what are the triggers of seizures? Triggers are very important because it gives you probably etiology. For example, I'll give you an example. Photic stimulation can be a trigger in juvenile myoclonic epilepsy. Early morning, the girl gets up, for a bright shine of sunshine, and she opens the curtain and she has a myoclonic jerk because of the sunlight. That's called photic trigger. Photic stimulation can also be there in other occipital lobe seizures, like photosensitive occipital lobe epilepsies. Early morning seizures can be there in epileptic spasms on awakening, and early morning seizures also very classically described in juvenile myoclonic epilepsy. Myoclonic jerks happen early in the morning. Sleep seizures I've mentioned, SELECTS, that is Rolandic epilepsy. Then you have nocturnal frontal lobe epilepsy, Panetopolis syndrome. All these have sleep seizures. Very important to differentiate these from, nocturnal sleep events, which are called parasomnias. Hot showers and fever are the characteristic triggers in Dravet syndrome. Every time the child has vaccination, fever, seizure, Dravet. Hot showers also one of the typical history which is given in Dravet. Noise-induced and action-induced seizures are very common in an entity called progressive myoclonic epilepsy. Then when you try to do an action when you have myoclonus, for example, if you outstretch the arm, then you have a myoclonic jerk. Or when you give a loud sound, like give a clap, then they have a seizure, myoclonic jerk. So that's a typical history of what you see in progressive myoclonic epilepsy. That's a different spectrum altogether. I won't go into the details of that. Catamenial seizures are basically exaggerated seizures of frequency or duration increasing during menstruation. that is because of your hormonal disturbances which are happening. It is not very specific, but it happen in a lot of seizures, a lot of epilepsies. So that these are the triggers, and this is the events. These are all the events which happen before the seizure. But what happens after the seizure also is sometimes important. It's called the postictal phase. So remember, postictal phase not only talks about confusion, drowsiness, sleepiness, confusion, headache, very important. Sometimes focal onset seizures, prolonged seizures like EPCs, that is epilepsy partial is continua, they can have thought paralysis as well. So and sometimes postictal phase also gives an information that it's a true seizure, not a pseudo seizure. These are the phases of seizure. Very important. What are the red flags? Sometimes non-epileptics are very common. Before you think that you have to definitely think it's a seizure or not. What are the red flags? For example, uh, don't label any patient as non-epileptic event directly. If there's a lateral tongue bite or a major injury, for example, a child won't fall and have a laceration on its head, and you don't say that it's a non-epileptic event, because if you have a major injury, lateral tongue bite, postictal drowsiness, during seizure, the child has passed, urine, that is micturition, defecation, headache, flaccidity, and during the whole event, the child's eyes were open, and the child sees during sleep. All these are very basic signs that you're treating. You're probably dealing with a true seizure, not a pseudo seizure. How to differentiate epileptic seizure from a pseudo seizure? Usually, seizures last around 5 to 10 minutes. Usually, but sometimes you can have status. That's a different question. Aura is blurred. Recollection of the whole event can be sometimes blurred because they don't remember the entire event clearly. And every time you have the same type of seizure, and head is sometimes fixed to one side, that is called a head version. That is a very good localizing sign and laterizing sign as well. And sometimes you have ictal urination and defecation. I will describe that. Autonomic changes, tachycardia, sweating, especially in a neonate. During a seizure, when you have tachycardia and a lot of fluctuations happening in the autonomic system, all these are favoring epileptic seizure, true seizure. And pseudo seizure, every time the duration is variable, sometimes lasting from hours to days, also sometimes. Aura is very clearly described, and every time it's a different semiology. It's asynchronous movements, side to side head movements, the eyes are closed. All these are events suggest a pseudo seizure. And sometimes it's not easy to just see and tell. Maybe you have to do an EEG, maybe you have to work up further to differentiate an epileptic and a non-epileptic event. So it's very important. It doesn't just go very easily by saying, one event and you have decided it's non-epileptic. No, you need to do more and more practice. You need to see the video again. We need to do investigations and then finally get to a diagnosis, because it's very important to diagnose the correct one, because over-diagnosing, even if you have a non-epileptic event, if you think that, I'll start levetiracetam, what's the big deal? If it's a seizure, it will control. If it's not a seizure, levetiracetam does not have any side effects. And that doesn't make sense, because you don't have a lot of questions. How long do you want to give? What is the dose you want to give? Why are you giving it? You won't be able to answer all the questions. So you have unnecessary medications. Even levetiracetam, which is commonly used, does have side effects. Like, there are a lot of behavioral side effects, aggression, violent behavior. It's known with levetiracetam. And in neonates, even if you have the subtlest doubt, the child had a problem, neonatal seizure, a subtle seizure, wherein he had just tachycardia, most of them start the patient of phenobarbital going on for 6 months, 7 months. No, it's not needed. There's no such protocol. And because even long-term phenobarb is known to cause cognitive decline in many studies. And not only just phenobarbital and levetiracetam, because I just gave these examples because they are commonly being used, but all the other anti-seizure medications, if it's not a seizure, do not use them, because there can be deadly side effects like Stevens-Johnson syndrome with lamotrigine and oxcarbazepine, weight gain with valproate, weight loss with topiramate, ataxia with phenytoin, hepatotoxicity with valproate. They are very deadly side effects. You need to understand why you're giving the drug. If it's really needed, you have to give. But what is the disadvantage of underdiagnosing it? But if it was truly a seizure and you just send the patient saying that it is not a seizure, it's a nocturnal event, non-epileptic event. It commonly happens in an adolescent girl coming to you. And not any adolescent girl coming to you will not be malingering or doing a non-epileptic event. You need to be neutral. Neurocystic cirrhosis tuberculoma will also happen in adolescent. Who says it doesn't happen? For example, a child with 12, 13 years can have autoimmune encephalitis. It's not necessary that any girl who walks into you at 13, 14 years will not be malingering. So what is the disadvantage of underdiagnosing? Who knows, the next episode you have explained the parents that it's not a seizure, don't worry, just take it home. What if it was truly a seizure? Next event, what if the child comes to you with status directly? So that's going to be a disaster. So bigger seizures, injuries, parental anxiety, distress, statal epilepticus, sometimes life-threatening status epilepticus can be there. And some seizures will have risk of sudden death during seizures, like SUDEP, that's called SUDEP. And if you have a long-term uncontrolled seizure, sometimes you have developmental arrest. Like if you see epileptic spasms are most commonly misdiagnosed. If you see most of the family members or grandmoms or neighbors will say that it's infantile colic, benign sleep myoclonus, GERD, reflux. They don't take to the hospital. Most of them, this epileptic spasm will miss for months and months together, and then you have developmental arrest and regression. So it should be diagnosed on time so that the child doesn't have regression and the seizures should be controlled. And in juvenile myoclonic epilepsy and adult onset epilepsy, if you have continuous seizures happening in the school, the child will have a lot of underconfidence and depression because of that, because they'll get bullied and mocked by their peers. I've already discussed this, how to differentiate a true seizure from epileptic seizure. I won't go into the details. And sometimes we may have to very well differentiate a seizure and a syncope. So syncope is a very common entity. See, for syncope, you'll have a situation and an environment, long-standing, prolonged standing. The child needs to be, a typical example, the child is in the assembly, standing for a long time in the sun, has not had his breakfast, not had enough hydration. All of a sudden the child fell, and during the end of the loss of consciousness, the child can have seizures. So the last end of the movement is called the myoclonic jerk. So in syncope, you have a loss of consciousness in the end because of the hypoxia, you can have myoclonic jerk. But in seizure, you have the jerks start before the loss of consciousness. You have jerks first, and then you have post-ictal drowsiness. In syncope, the entire event is very important. I mean, long-standing dehydration. I mean, hypoglycemia, the event, the circumstance, all these are very important, and the child rapidly recovers. And these are some of the clues for syncope. In a seizure, you have more well-defined event, which is you have tonic-clonic movements and then followed by loss of consciousness. Sometimes the witness, nobody must have witnessed exactly, because in both the conditions you have loss of consciousness. In that condition, maybe you have to maybe look into the situation where the child is standing, sitting for a long time, had breakfast, and all that will help. And even after that, you need to sometimes get ECG, EEG to rule out seizures, ECG and echocardiogram to rule out any cardiovascular dysfunction. The common syncope cause is basically vasovagal syncope, because that is because of the autonomic instability of the patient. And ECG and E2D will be usually normal. But sometimes cardiac causes can also cause aortic stenosis. All these can also predispose to syncope, and sometimes or WPW and arrhythmias can also present as syncope. So you need to rule out secondary causes before you label vasovagal syncope. So this is where I end. I think in the next session we'll be taking up each type of semiology and various videos, clinical videos of what kind of seizures, and that is going to be an interactive session. And the third session will be on epilepsy syndromes. Thank you.